Hello, everyone, and welcome to our first module on antiarrhythmic drugs. The way that most antiarrhythmic drugs work is that they prevent the formation of electrical impulses. And the idea here is that these drugs generally slow electrical activity in the heart, and that will either stop an arrhythmia that's already occurring or it will prevent one from occurring in the first place. So in general, the antiarrhythmic drugs we're going to talk about in this video are used to terminate or suppress arrhythmias. By terminate, I mean break arrhythmias that are ongoing and restore sinus rhythm. And by suppress, I mean to prevent the development of arrhythmias in the first place in situations where they're likely to occur. Now, one thing that can be confusing about these drugs, but that you have to understand, is that most of them can also cause arrhythmias. Even though they're designed to treat certain arrhythmias, they can also cause other ones. So this can potentially lead to cardiac arrest and death in patients who take these drugs. So for this reason, for most antiarrhythmic drugs, they're only used in dangerous arrhythmias or in recurrent, highly symptomatic arrhythmias. We don't use them all the time because of the risk of causing an arrhythmia. So just to give you a picture in your mind of how some of these drugs could be used, so imagine that a patient has persistent and recurrent ventricular tachycardia, which is shown here. This is a life-threatening arrhythmia, and this is a situation where you could use an antiarrhythmic drug to stop the ventricular tachycardia if it's ongoing and to keep it from starting again. The bottom of the screen is an example of rapid atrial fibrillation. This can be highly symptomatic in some patients. So we might use an antiarrhythmic drug in this situation to stop the atrial fibrillation if it's ongoing or to keep it from coming back once it's gone away. The antiarrhythmic drugs are traditionally broken down into four groups by what's known as the Vaughan-Williams classification system, and that's what's shown on this slide here. So by this system, antiarrhythmic drugs are divided into groups based on their mechanism of action. So all of the class 1 drugs are drugs that block sodium channels, and we'll talk about what this means later. And there are three subtypes of class 1 agents, the 1A, 1B, and 1C drugs. Class 2 drugs are antiarrhythmics that are beta blockers. Class 3 drugs are all potassium channel blockers. And finally, the class 4 drugs are calcium channel blockers. And so in this video, we're going to mostly focus on the class 1 drugs. In other videos, I'll talk about drugs that fall into the other groups. Before we get into specific antiarrhythmic drugs, let me give you some general principles about the mechanisms by which these drugs work. So like I said before, the idea behind all the antiarrhythmic drugs is to slow cardiac electrical activity to either stop or prevent arrhythmias. And as I mentioned on the last slide, the class 1 drugs all block sodium channels, and they affect the myocyte action potential, which is shown right here. I talk about this in detail in another video, but in a minute, I'm going to tell you how all the class 1 drugs affect this action potential. The class 3 drugs, like I said in the last slide, all block sodium channels, and they also affect the myocyte action potential shown here. And then the class 2 and 4 drugs, which are beta blockers and calcium channel blockers, they work on the pacemaker action potential, which is different, and that's what's shown here at the bottom of the screen. So those drugs, their major effect is to slow sinus and AV node conduction because that's where this action potential is important. So let's zoom in on the myocyte action potential for a minute, which is the action potential that occurs in cells in the atria and the ventricles. And I talk about this action potential in detail in another video, but by way of quick review, phase 0 of this action potential depends on sodium channels, and that's what causes this rapid increase in voltage across the cell membrane. So when you block sodium channels, what it's going to do is disrupt this phase of the action potential. And in the heart, in the ventricles, you have thousands and thousands of myocytes going through this action potential at the same time. And that's what generates the QRS complex when all those myocytes depolarize by going through phase 0. So anytime you block sodium channels, you're going to disrupt this phase of the action potential, and that can potentially affect the QRS complex. And it's high yield to understand that. We'll come back to this more and more in this video. And now I've cleared away my ink so we can talk about the class 3 antiarrhythmic drugs. As I said earlier, those drugs block potassium channels. So where is potassium important in the myocyte action potential? Well, it's important here in phase 1, it's important here in phase 2, and also here in phase 3. So when you block potassium channels in myocytes using an antiarrhythmic drug, that's going to cause phases 1, 2, and 3 to take longer to occur. It's basically going to draw out the duration in time of this entire action potential. And so that's what's going to happen to an individual myocyte. But when you inhibit the potassium channels in all the thousands of myocytes in the left ventricle, what you're going to see on the EKG is that the QT interval is going to become prolonged. The QT interval is the time from the start of the QRS complex to the end of the T wave, and it represents the time for repolarization of all the ventricular myocytes. And so when you give a class 3 antiarrhythmic drug that blocks potassium channels, you slow down the myocyte action potential and you can prolong the QT interval on the EKG. This is in contrast to the class 1 antiarrhythmic drugs, which block sodium channels. Those drugs slow down depolarization, not repolarization, and therefore they can prolong the QRS. In contrast, the class 3 agents that block potassium channels can prolong the QT interval. So just to make this very clear, when you use antiarrhythmic drugs that block sodium channels, they target phase 0 of the myocyte action potential shown here. And by blocking sodium channels, you're going to slow down phase 0. So the myocyte action potential is going to shift from what you see in blue to something like what you see in red. And when you do that to lots of the myocytes in the ventricles, that can potentially prolong the QRS complex. And so that's the EKG change that sodium channel blocking drugs can affect. They can prolong the QRS. In contrast, when you use antiarrhythmic drugs that block potassium channels, those drugs are going to target these phases of the myocyte action potential. That's when myocytes are repolarizing, and the potassium channel blocking drugs will prolong the process of repolarization. It will switch the myocyte action potential from something like what you see in blue to something like what you see in red. And when all the ventricular myocytes repolarize, that's what generates the QT interval. This is the time it takes for all the myocytes in the ventricles to repolarize. And you're going to stretch or prolong that time out by using potassium channel blocking antiarrhythmic drugs. So that will prolong the QT interval, which is the time from the start of the Q wave to the end of the T wave. And as you may know, because I've talked about this in other videos, anytime the QT interval prolongs on the EKG, that puts patients at risk for the dangerous form of ventricular tachycardia called torsade de Pointes, which is shown here. So quick review, torsade de Pointes is a subtype of ventricular tachycardia. It's a life-threatening cardiac arrhythmia, and it's the feared outcome when the QT interval prolongs on the EKG. And we're going to be talking about a lot of QT prolongation from the antiarrhythmic drugs, so you need to understand that any of those drugs that prolong the QT interval can potentially cause dysarrhythmia, and it will result in cardiac arrest. And so as we'll see soon, the class 1A antiarrhythmic drugs and the class 3 drugs all can prolong the QT interval, and therefore this arrhythmia is a potential adverse effect. And this goes back to what I talked about in the first slide, which is that even though antiarrhythmic drugs are used to treat arrhythmias, they also can cause arrhythmias. And one of the ways they can do that is by prolonging the QT interval and causing torsade de Pointes. All right, one more quick point before we get into specific antiarrhythmic drugs. The time from the start of phase 0 in the myocyte action potential to the point where the voltage has come back down to minus 85 millivolts, that's called the action potential duration. There's a related time period called the effective refractory period. This is the time it takes before the myocyte can potentially depolarize again. It turns out myocytes can depolarize again before they get all the way back down to minus 85 millivolts. When they start to get close to that value, they can depolarize again. And the time to reach that point is called the effective refractory period. So both of these times, the effective refractory period and the action potential duration, can be altered by antiarrhythmic drugs. And we're going to talk about that as we go through the drugs in this video. Okay, so now that we got through all those general principles, let's start talking about specific antiarrhythmic drugs. And we'll start with the class 1 drugs by the Vaughan-Williams classification system. And as I told you before, those drugs block sodium channels, so they can all potentially prolong the QRS interval. Not all of them do, but they can. Some of them also affect potassium channels. This is just a confusing quirk of the class 1 drugs. And those that have potassium channel blocking effects can prolong the QT interval, just like we talked about in the last few slides. Many of these drugs can prolong the action potential duration. They can also prolong the effective refractory period. So all of these are potential effects of the class 1 drugs that block sodium channels. The class 1 drugs are divided into 3 subtypes, the 1A drugs, the 1B drugs, and the 1C drugs. And they're divided into these subtypes based on how the drugs bind with the sodium channels and their effect on the action potential. So all the 1A drugs do what I've shown on this image right here. They move the action potential for myocytes from the blue to the red one. So they block sodium channels, and that affects phase 0 right here. They also have some potassium channel blocking effects, which causes them to extend repolarization like this, like you see here. So because of those effects, the class 1A drugs can prolong the QRS interval and the QT interval, and they prolong the action potential and the ERP. The class 1B drugs are a strange group. They actually slightly shorten the action potential duration. We'll talk about these in a minute, and I'll explain this in more detail. But they basically have very little effect on the QRS complex, and they can shorten the QT interval, and they shorten the action potential duration and the ERP. And then finally, the 1C drugs mostly affects phase 0, like shown here, so they can prolong the QRS interval. They don't have much effect on the QT interval, and they don't have much effect overall on the action potential duration or the ERP. Okay, so now let's talk about the class 1A drugs in a little more detail. Some examples of antiarrhythmic drugs in this group include quinidine, procainamide, and disopyramide. They all affect phase 0 of the action potential, so that can prolong the QRS complex duration, as we've discussed. They also have some effect on potassium channel outflow from the cells, and so that can prolong the QT interval like what's shown here. And then these drugs all increase the action potential duration and the ERP. Let's talk in a little bit more detail about one of the 1A antiarrhythmics, and that's procainamide. It has some special features that you should be aware of for your step 1 exam. So first of all, you should be aware that this drug slows conduction in accessory pathways in patients who have the Wolff-Parkinson-White syndrome. I talk about WPW in its own video, but in patients who have arrhythmias associated with their bypass tract in WPW, you can use procainamide to slow conduction over the bypass tract. You should also know that this drug is one of the 3 drugs that classically cause a drug-induced form of lupus. The 3 drugs that do this are isoniazid, hydralazine, and procainamide. There are others, but these are the 3 that are most commonly tested. And so patients who are on procainamide after a few weeks or months can develop a lupus-like syndrome where they get a malar rash, arthritis, and anemia, and their ANA antibodies can be positive. One unique feature, though, that's only seen in drug-induced lupus is positive antihistone antibodies, and it's high yield to remember that. And the whole drug-induced lupus syndrome resolves on stopping the drug. Disopyramide is another class 1A antiarrhythmic drug that has some special features you should know about for your board exams. So one unique thing about disopyramide is that it has negative inotropic properties. This is a feature of this drug outside of its antiarrhythmic effects. So for this reason, you'll read that this drug can cause heart failure, and that's because it's a negative inotrope. And we generally don't give it to patients who have a reduced left ventricular ejection fraction because it can make their cardiomyopathy worse and cause heart failure. You should also know that this drug has a special niche use, and that's in patients who have hypertrophic cardiomyopathy and outflow obstruction from the left ventricle. I talk about what this is in detail in the video on hypertrophic cardiomyopathy. But because disopyramide has negative inotropic properties, it decreases the strength of ventricular contractions. And when there are less vigorous contractions, that leads to less myocardium getting in the way of blood leaving the left ventricle and therefore less outflow obstruction. And so that's why disopyramide is sometimes used in cases of hypertrophic cardiomyopathy with significant outflow obstruction that's symptomatic. It's usually a second-line agent after beta blockers and calcium channel blockers, which are safer drugs. Okay, moving on. Now let's talk about the class 1B antiarrhythmic drugs. These are also sodium channel blocking drugs. Examples of 1B drugs are lidocaine and mexiletine. Basically, they're very similar drugs, but mexiletine can be taken orally and lidocaine is given intravenously. These drugs have the effect on the action potential shown here. They generally have no effect on the QRS at normal heart rates. As you can see here, they really don't affect phase 0 of the action potential. And they actually cause a slight decrease in the duration of the action potential, and therefore they can slightly shorten the QT interval, and this is relatively unusual for antiarrhythmic drugs. And in general, these drugs have the least effect on the action potential of all the class 1 drugs. So what makes these 1B antiarrhythmic drugs useful is that most of the sodium channel binding they do is when the myocyte is in a depolarized state. So if you look at the action potential here, the myocyte depolarizes, and that's when the voltage goes up like this. And at this point up here, that's when you find most sodium channels in the depolarized state. And that's where the 1B drugs do most of their blocking. And it turns out when there's ischemic myocardium, there tend to be more depolarized myocytes because of the ischemic damage to the cells. And so that makes lidocaine and mexiletine and 1B drugs effective in ischemic arrhythmias where there are lots of depolarized myocytes, because that's when these drugs will bind best to sodium channels. Another feature of these drugs that makes them useful in ischemic arrhythmias is that these drugs rapidly unbind from sodium channels. So when heart rates are slow, the drug will often completely unbind after one depolarization and be unbound by the next heartbeat, so that the next heartbeat occurs with no effect of the drug. But when the heart rates are fast, there's less time for the drug to unbind from sodium channels before the sodium channels open again and depolarize. So the bottom line is you tend to get more effect of these drugs when heart rates are faster. And so that makes them very useful in ischemic tachyarrhythmias, especially ischemic ventricular tachycardia. Because in this situation, you have fast heart rates, which makes these drugs work well, and also depolarized sodium channels, like I said in the last slide. And so lidocaine, which is intravenous, is sometimes used in patients who are having myocardial infarction and developing ischemic ventricular tachycardia. Some other things to know about the class 1B drugs. Lidocaine, you may be aware, is also used as a local anesthetic. I talk about local anesthetics in the neurology section, but because lidocaine blocks sodium channels, it can be used as an anesthetic to block sodium channels in nerves. The 1B drugs can also cause CNS stimulation. This presents in the patient as tremor and agitation. So a sort of classic board question, at least on the cardiology boards, is a patient who's on mexiletine, which is oral for some reason, then develops a tremor. That patient is having toxicity from the drug. And then finally, these drugs can cause cardiovascular side effects if you block too many sodium channels in myocytes. This can lead to bradycardia, heart block, hypotension from low cardiac output. This is all related to blocking too many sodium channels in the myocytes of the ventricle. All right, the last group of class 1 drugs are the 1C drugs. Drugs in this class are flecainide and propafenone. Just like all the class 1 drugs, they block sodium channels, but these drugs have very slow unbinding. So for that reason, they really slow down phase 0 of the action potential here. And for that reason, they can markedly prolong the QRS complex. Just like we talked about earlier in this video, drugs at slow phase 0 can prolong the QRS complex. And if your QRS complex gets too long, that can lead to arrhythmias. And so these drugs have very limited use because of this toxicity. There are a lot of pro-arrhythmic effects of the class 1C drugs. If you want to understand why the 1C drugs aren't used much anymore, we have to go back in time a little bit. Decades ago, there was a very famous trial called the CAS trial, cardiac arrhythmia suppression trial, which showed how dangerous the 1C drugs can be. So this trial, the CAS trial, tested what's known as the suppression hypothesis. So it was hypothesized that suppressing arrhythmias is a good thing. And so patients who had asymptomatic arrhythmias after MI, like maybe a few PVCs on their EKG, these patients were all given drugs like echinide or flecainide to suppress those PVCs, the thought being that if you suppress the PVCs, you'll end up suppressing arrhythmias. Well, it turned out that these drugs did suppress those arrhythmias. Patients taking the drugs had less arrhythmias. But when they did get arrhythmias, they had a 3.6-fold increase in the risk of dying from one of them. So the result was a major decrease in the use of these drugs after the CAS trial. This really changed practice. And this is one of the reasons you'll read that flecainide and related 1C drugs are contraindicated post-MI. It all comes from this CAS trial here. So you'll read in your textbooks and in UpToDate that the 1C drugs are only used in patients with structurally normal hearts. And this means patients who have a normal left ventricular ejection fraction and no prior history of myocardial infarction. And this is all fallout from the CAS trial. These drugs aren't used in patients who are similar to those in the CAS trial. Those patients had MIs and had reduced ejection fractions. The sort of niche use where you'll sometimes see these drugs in clinical practice is in reducing the recurrence of atrial fibrillation. Patients are given these drugs when they're in sinus rhythm, and it makes them more likely to stay in sinus rhythm and not go back into AFib. When you do this, though, you have to monitor for QRS prolongation on the patient's EKG. If the QRS complex starts to prolong, then you need to stop the drug. Otherwise, there's a risk of cardiac arrest. These drugs also have a special feature called use dependence. So let's talk about what that means. So sodium channels fluctuate between 3 different states. And if you look at the action potential down here, when myocytes are in phase 0, sodium channels are open. When myocytes are up here in phase 1 and the beginning of phase 2, sodium channels are in the inactive state. And then when you get back down here, sodium channels are in the resting state. Many antiarrhythmic drugs bind more in one of these 3 states, and all the class 1 drugs bind best in either the open or the inactivated states. These are said to be states when sodium channels are in use, as opposed to the resting state when they're not in use. And so we say that the class 1 drugs exhibit use dependence, meaning they're more likely to bind sodium channels in the open or inactive state when they're being used. This feature of the class 1 drugs to have use dependence has a real-life clinical implication for when patients are most likely to develop toxicity. So to understand this, on the screen I've shown two EKG tracings. At the top is a patient with bradycardia, at the bottom is a patient with tachycardia. And I've shown 3 seconds of time. So in the top tracing, there's only 3 QRS complexes during 3 seconds because the patient is bradycardic, and sodium channels are only open and inactive when either the QRS complex is going on or just before repolarization. But all this time in here, the sodium channels are in the resting state. So if you look at the bradycardic tracing at the top, you can see there's relatively little time when the sodium channels are in the open or inactive state. But now look at the tachycardic patient at the bottom. You can see there's much more time where the ventricular myocytes are going to spend in the open or inactive state. And this means there's much more ability for the drugs to bind in tachycardia. And that's the key thing to know about use dependence. Antiarrhythmic drugs that display use dependence are more likely to cause toxicity when the patient is tachycardic compared to when the patient is bradycardic. And that's because during tachycardia, sodium channels spend more time in the open or inactive state. So just to emphasize this point, I've written it on this slide. Use-dependent drugs have more effect with fast heart rates. Now, all class 1 drugs have some use dependence, but it's seen most frequently with the 1C drugs. The 1C drugs are famous for use dependence. And so this has a practical implication. If you're going to give a patient flecainide or propafenone, which are 1C drugs, and you know they have marked use dependence, that patient is most likely to develop toxicity, meaning QRS prolongation and arrhythmias at high heart rates. And so what we do when we put patients on flecainide and propafenone is after they've been on it for a little while, we do a stress test. And we're doing this to make sure that their QRS does not prolong at high heart rates, because if it does, then the patient's in danger and we need to either stop the drug or back off on the dose. And this is all because of this feature of the 1C antiarrhythmic drugs use dependence. And that concludes our first module on antiarrhythmic drugs.